All right, welcome. So I'm Dr. Joseph Finney, a pediatric emergency medicine and EMS physician at St. Louis Children's Hospital and the director of EMS for St. Louis Children's Hospital. I'm here with Steve Laffey, who's a pediatric emergency medicine physician at Cardinal Glennon Children's Hospital and the director of the STARS program at Cardinal Glennon. And we're going to talk about IOs. And Steve, I'll let you kind of lead off.
Yeah, they're life-saving. They're amazing. We've been using them for years. It's interesting, if you go back, they actually were first described like in the 50s. And like so many things that we think are new, turns out they weren't really all that new, but the first kind of realization that you could put something from the bone marrow and get into the central circulation is actually quite old. The biggest change over the years with IO needles has been the IO gun. That's really where we changed. Changed the whole game as far as placing IOs. The old IOs that we used were either Jamshidi needles or Cook IOs purely by hand. It took a lot of work. It was traumatic. I mean, you really had to work. And so the Easy IO or the IO gun really has been a kind of a game changer. It went from, I did way more IOs than anyone else, and the paramedics rarely did it, to now it's the exact opposite, right? The paramedics are putting in more than we are.
Yeah, I think IO has really kind of become the new sort of primary point of access.
Exactly.
And, indications for this procedure, you can sum it up simply in one statement. You need rapid access and you can't get it any other way. That's when an IO is indicated. I think we worry about mental status and things like that I think should be less of a concern. If you're in a situation where you need rapid access, then you need to give that medication through an IO. Steve, you want to talk about maybe some locations where we could put an IO in a pediatric patient?
So classically, we've always talked about the proximal tibia. Just below the tibial tuberosity, you want to avoid the growth plate there. And what you're aiming for there is the flat part of the tibia. The tibia has that flat edge, exactly. That's what you want to do, is you want to get to that flat edge of the tibia. And we know that's a little bit medial. This mannequin actually is good because the way he is laying is the way babies lay when they're floppy. They kind of have their legs splayed out. And be very careful, before you get your landmark, get that leg straightened back out again, because you want to go down and then a little bit over medial like this. What I see happen a lot is people go here and then they go medial, and then what happens is you straighten them out and they're actually sticking that IO needle into the side. So get your leg straightened out first, find your tibia tuberosity, then go medial. And feel for that flat part. You want to get right in the middle of that flat part.
Yeah, and you want to be perpendicular to that bone, right? So you want to think about the bone in a three-dimensional space, because really that bone is triangular shaped, and so you're going for that flat part on the side. And I think, Steve, that's a great location. I think it's the most common location that's used. It's not the only location that the AHA technically recommends. So you want to talk about the femur?
So distal femur, the reason that we never use the distal femur, practically speaking, is that bone did not take very long before there's no way you could penetrate that bone with one of those old hand drill. This was the thin bone. And even then, by the time you were 4 or 5, it would be a real bear to get it in there. But these drills have kind of changed everything, so there's no reason you can't get in. The good thing about the distal femur is it's a bigger marrow space, so you've got more room for error.
And it's easier to identify sort of in your mind. You can put your hand on both sides of the femur and identify where it is right in the middle. And so I think that makes it a little bit easier too.
Exactly. Just above the kneecap, and again, just a little bit medially. Make sure you start off with them kind of lined up so you can get your landmarks appropriately.
I think that's great. And then the last location is obviously the humerus.
Yeah, and I think if you're for the adult world, I think that's a much more common use. The landmarks aren't as easy to find sometimes in the little kids, and even more importantly is their humeral head in that area up there is not nearly as well calcified, so it's a lot of cartilage, and it's not amenable to getting an IO needle in. So I think you had a good kind of helpful hint as to when you might want to be using that.
Yeah, so I recommend that the humeral IO, proximal humerus, is good in any kid with obvious signs of puberty. So that gives you an indication, like Steve's saying, that the patient has ossified that bone enough that it's going to be able to receive the needle, as opposed to, if you put it in a bone that's sort of still, developing and soft, it's going to come out right away. And speaking of that, Steve, you want to talk a little bit about infiltration and
so that's become kind of a pet peeve of mine, is the idea that an IO can infiltrate, or in other words, it was perfectly fine, we nailed it, it was in there, and now it's no longer in there. So think about what that implies. Think about, so you've got a needle and it's inside them, and you used a drill to get it in there, right? You actually drilled it through the anterior part of the bone. And somehow, what we're implying if we're saying it's infiltrated, it can only come out in one of two directions. It can either come out this way,
Yeah.
in which case it's going to be floppy and
Yeah.
it's easy. The only other way it can quote unquote infiltrate is to somehow work its way all the way through the other side of the bone. There is no way that an IO needle under normal use is going to somehow work its way through the other side of the bone. It required a drill or a lot of effort to get it through the top side. It doesn't just randomly go through the other side. What's happening when they infiltrate, it's an IO that was never in the first place. And I think what we're probably not doing as much of is giving a really good fluid bolus right off the bat to make sure that we're in the right spot.
And the reason that fluid bolus is important is because, you know, the tissue has to swell up a certain
before
amount
you know.
before we even identify it. So if we give 10 cc's into the thigh, probably not going to notice that. After 250 cc's go
Right.
in, then
Then
we're
you'll
saying,
see.
okay, it's potentially
It's infiltrated, but
yeah.
it just was never in. Pretty profound implications of that, right?
Right.
That means that everything that we put into there really wasn't doing any good.
Yeah.
Epinephrine or fluid or whatever other medications,
Yeah.
none of that was actually being effective. So we need a better way to determine whether these needles are in. I know there's been some talk about using ultrasound or something like that
Yeah.
to maybe document, but wow, I really wish we had a better way to know for sure that those needles were in the marrow space.
Yeah, well, let's talk a little bit about needle size and how that can be, you know, what size you're supposed to use. You know, so the way I think about it is, you know, there's obviously pink, blue, and yellow. I think of pink needles for basically patients who have a placenta in the room, right? If the
Exactly.
baby was just born,
Right.
then you can use a pink needle. Outside of that, they're gonna be too big, especially if you're using the femur.
Oh my gosh.
It doesn't take very long for that to be a site that's no longer gonna be amenable to that short needle.
The problem is that pink needle on the package, it says 3 to 39 kilograms. And that was just crazy. It's ridiculous.
Back
So
in the
if you-
50s, maybe.
Yeah, right. So you just have to realize, and there's multiple, again, not just with us, I mean, all around the country, multiple documented cases of those pink needles not being appropriate.
Yeah, so I say those are for your bulletin board and use the blue. It's going to be for most of your pediatric patients. Yellow, kids who are past puberty, who are basically, you know, nearing adult size, or some of our bigger patients. The reason we say that is you'll see there are black markings. The reason those are on there is because when you place the IO, the first thing you're supposed to do is really just penetrate down until you hit the bone. So you don't just put it in and drill. You need to get down to the bone so that you can make sure you identify at least one line still above the skin. If you can't see a line, you don't have enough space to reach into that marrow. So that's really, really important. You know, everybody just sort of drills. First step is insert it, make sure you can see a line, and actually, Steve, you know, I learned this from the manufacturer, you don't even have to apply pressure. You know, that's how you're able to sort of drill into an egg. The bevel will drill itself into the bone. You just sort of gently set it there and let it do it. So,
Yeah. Another thing to keep in mind, there is no such thing as an IO needle that's too big. That just is first of all, the needle itself is the same. There isn't a difference in the actual needle. So the gauge and the size of the needle is the same for all three of them. Talk to somebody who used to put in the old Cook or the Jamsheedis. We had one size needle, it was about that long. We put that into every single patient, baby or otherwise. Never once did I think it would be nice to have 3 different sizes of needles. So if it's a really long needle, you just don't put it in as far. There's no such thing as being too long.
yeah, do not fear exposed needle.
Exactly.
The adapter will actually expand. So let's say you are slightly above the skin. This will telescope up and down so that you can secure it into place regardless of the size. A couple other real quick things I want to mention, because we promised we would keep this video short, is that you have to make sure you take the core out before you attach it to anything, right? So 2 mistakes that happen. One is you take it out before you drill it, and then you put this in. That's not going to do any good. That's a nail, right? So that's not, and you can't pass any fluid through that. And the second mistake you make is you try and attach things to it when this is still in place. And I see it all the time because you're trying to do so many things, you forget that there's that extra step. So be sure to remove that core part. I always say aspirate first, but obviously aspiration doesn't guarantee. If you don't get anything back, it doesn't mean you're not in the space, but a strong flush of fluid is really going to be the most important thing, to make sure that you're in the right spot. So just to summarize, pink needles, keep those for your, for your babies and for bulletin boards. Keep the blue for most of your pediatric patients, yellow for bigger kids, proximal tibia, distal femur, proximal humerus, all great locations. Your goal is to get it to as close to central circulation as you possibly can. And then just think about pushing it down first, meet that bone, make sure you've got black line before you then penetrate into the bone marrow. Otherwise, you might not know if you have enough space or not. And then a strong flush of fluid afterwards.
Yep, I agree.
All right, well, thanks guys so much. Definitely reach out if you have any questions or concerns.